Okay, so it's 12:03, so I think we'll get started. So you're very welcome to today's CPD webinar. My name is Michelle Leach and I am Professor in Radiation Therapy at Trinity College Dublin here in Ireland. And I will be the moderator for today's webinar. So I'm delighted to be joined by my colleague, Maeve Kearney, who is an assistant professor here in the discipline of radiation therapy. And Maeve is a member of the ESTRO, the European Society of Radiotherapy and Oncology ROSC committee. And within that capacity, she was representing ESTRO on a recent EU project called the Marlin project. And that's what she's going to speak to us about today. So Maeve, if I can ask you to share your screen, please, when you're ready.
There we go.
Brilliant, it's coming there now. Yeah, and if you just into slideshow, perfect, that's great. So just, I suppose, a couple of housekeeping rules is probably too strong a word, but if you want to ask a question, if we can ask you to please put it in the Q&A section, not the chat, so in the Q&A, and we can ask Maeve any questions that come up at the end. Otherwise then, Maeve, I'm going to hand over to you, and we're looking forward to hearing your talk. Thank you.
Great. Okay. Thank you very much, Michelle, for that introduction. So I'm delighted to discuss with you just some of the insights from the EU Marlin project and just essentially advancing quality and safety in radiation therapy through incident learning systems. So throughout this webinar, I'm going to talk about Marlin in the context of the EU SAMIRA action plan, like what do all of these things mean at an EU level? A little bit of background in quality and safety in RT, because obviously this is something that, you know, I was really taking into consideration with my contributions to this project. And then the actual Marlin project, how we got to the point of creating consensus guidelines for incident learning systems in ionizing radiation. So if we talk about, you know, the Marlin project, well, it comes really from the Europe's Beating Cancer Plan. So this was launched in 2021. So it's a key pillar of the European Health Union. So launched by Ursula von der Leyen in 2021. It's a massive investment basically in a cancer strategy at an EU level. It's €4 billion investment. And it came about after COVID because during COVID, we possibly lost some of the gains that we had made, you know, in cancer control. Because everything obviously was, you know, the priority of cancer obviously, you know, slipped down a little bit. So it was really just kind of like, you know, rebooting, you know, the effort for Europe's Beating Cancer Plan. And very positively, there was strategies at every level of the cancer care paradigm, from prevention, diagnosis, treatment, and quality of life and patients and survivors. So the Marlin project would have fell into the treatment aspect here. So we can't talk about Marlin without talking about SAMIRA. So SAMIRA, we love an acronym at an EU level. So the Strategic Agenda for Medical Ionizing Radiation Applications. So SAMIRA had basically three remits within that Europe's Beating Cancer Plan. So securing the supply of medical radioisotopes, facilitating innovation and the technological development of medical ionizing radiation applications, and then improving radiation quality and safety in medicine. So improving radiation quality and safety in medicine, okay, which comes from the SAMIRA branch of the Europe's Beating Cancer Plan. Within that, there was Quadrant. Okay, so Quadrant is looking at, you know, providing recommendations for clinical audits where there is medical radiological practices taking place. Then the EU RES project. So the EU RES, so that would stand there for radiation education and study and training. And this was a project basically looking at workforce availability and what you need in terms of a workforce in order to be able to deliver medical radiation and ionizing radiation applications like safely. And then the Marlin project, okay, which is medical applications of radiation, learning from incidences and near misses, which gives us our acronym Marlin. So Marlin had basically the aim of Marlin is to support the implementation of this directive into clinical practice. So Article 63, which relates to accidental and unintended exposures. It is more commonly known as the BSSD, Basic Safety Standards Directives. And basically there was two articles specifically. So these are all available online, this legislation, if you want to read through it, it's all readily available online. But basically what Marlin was hoping to do was support These specifically declare as soon as possible to the competent authority the occurrence of significant events as defined by the competent authority. And the results of the investigation and corrective measures to avoid such events are reported to the competent authority, which within the time period specified by the member state. And then mechanisms are in place for the timely dissemination of information relevant to radiation protection in medical exposure regarding the lessons learned from significant events. So that was the aim of Marlin, to support the implementation of these directives specifically. So the basic safety standards directly, if we just to kind of, just to summarize that overall, it really underscores the crucial role of an incident learning system in reporting and learning from patient-related incidents and near misses in ionizing radiation medical applications. So this covers the entire spectrum, which Marlin did: radiotherapy, interventional cardiology, nuclear medicine, and interventional and diagnostic radiology. So the consortium was made up of experts from each of these areas, because it is very important that there was people there to present the specificities of each of these areas, because they are very different. While they fall under medical ionizing radiation, they are all very different. And it does mandate establishing a framework to ensure that unintended and accidental exposures are reported, analysed, and findings disseminated to mitigate future risks, thereby enhancing patient safety. Because what can happen when it comes to incidents is it became about reporting rather than the learning aspect here. So this is something that, the Marlin Project and the consensus guidelines was trying to address, that we were meeting just not the reporting, but the whole incident learning system, which is very much the learning from this, the dissemination of the lessons from this, to try and minimize this happening again. So how are we going to do this? So we were going to provide a comprehensive description of the current status of incident reporting across the EU 27 countries, because if you're going to have consensus guidelines, it is a good idea to know what people are currently doing, and then to develop consensus guidelines on reporting and learning across medical applications in ionizing radiation. So that would include, like as mentioned before, radiotherapy, interventional radiology, cardiology, nuclear med, interventional and diagnostic radiology in Europe. So we really had two specific objectives to meet this aim. So the Marlin Project was a 24-month project with a budget of just under 250,000. So the consortium was led by the European Institute for Biomedical Imaging Research. So that was the lead contractor, and essentially ESTRO and EFOMP were brought in as expert members of this consortium. The EIBIR, they're involved in many different projects. You can see on their website the range of projects that they are involved in. And within the EIBIR, they would have experts in this area as well. So overall, we had a very comprehensive consortium representing, the full spectrum of medical ionizing radiation applications. So Marlin, as I mentioned there, across all of the applications in medical ionizing radiation. Now, the main stakeholders for incident learning systems who were going to be involved in creating these consensus guidelines: competent authorities. Okay, so the competent authorities, do need to define what a significant event is, and also have a process in place for reporting, for centres to report these incidents, and also some type of system in place for analysing it and disseminating the lessons learned from it. Clinical facilities obviously is the biggest one here, because this is where the incidents are going to be occurring, and having a very established system there for reporting and learning. And then, of course, the professional societies, while they're not mandated for or legislated for within that directive, it's a group that we could not really ignore here, because professional societies, they do advocate for their members, the healthcare providers, and it is within their interests as well to be constantly, advancing that profession and, advancing the best practices when it comes to the provision of healthcare. So these were the main stakeholders in creating the consensus guidelines. So incident learning systems in RT. So I just want to give a small background on this, because obviously, they're quite established in RT. So we weren't really starting off with a blank canvas here at all. It was just more kind of, developing these consensus guidelines. Incident learning systems in RT. So indicated radiotherapy. I know the audience here is largely radiotherapy, but, indicated in 50% of patients with a cancer diagnosis. So it is it's a considerable treatment modality in the treatment of cancer. 50%, there very much is well publicized that it is underutilized, but that is obviously a conversation in a webinar for another day. And if we look at it in the context of Europe, in 2019, there was about 635,000 courses delivered of radiotherapy, and it is relatively safe. It's a relatively safe medical procedure. We have incidents from about 1.5 to 8 incidents per 100 courses of treatment on average. That's the latest incident, or the latest kind of statistics. And 1 in 30,000 of them will result in a significantly adverse clinical outcome, where this will affect a patient. So clinically as significantly adverse. So, 1 in 30,000, it is rare. Obviously, want that to be as low as possible. It's best patient, you want to deliver the best treatment to the patient, but overall relatively safe. It is compared often to the aviation industry in terms of like how safe it is. Now, this good safety culture, okay, it is there. It's there for a few reasons. Why? Well, again, I'm probably preaching to, the audience here that is very radiotherapy focused. We're dealing with very high total doses. Not only that, but the complex patient pathway. And this is something, as the radiotherapy contributor to this project, is just like that complex patient pathway and resulting in a customized treatment plan for each patient. Even if it's prostate cancer, even if you have a hole in your accelerator with prostate cancer patients, they all have a different plan. And that is there's a large chain, a very complex patient pathway with safety barriers in place, because there is so many places where things can go wrong. So this is why we do have our safety barriers in place, and we do have a very, very good safety culture. This is one of the reasons. Also, okay, fortunately, these incidents are becoming rare and rare, but when an incident does happen within radiotherapy, it can be quite serious. Patients have died, okay, and it does get publicized. It does make it to the press. It's just a selection here. Staffing shortage, radiation error, report blames shortages, lots of talk about shortages, and then cancer error well handled. Transparency here, trust of the public. Okay, this is very, very important. But so that is why, what we're doing, that we're very transparent about, how incidents are reported, but also how they are analyzed afterwards and what happens when there's an incident. So, this will all get to the press. It is very important that we're constantly, maintaining our trust in the public that we are providing the best quality and safety in radiotherapy delivery. Also, incident learning systems. This is something that we really wanted to prioritize and to really emphasize and highlight when we were creating these consensus guidelines within the Marlin project. So this is just a phrase from Professor Sir Liam Donaldson. So to err is human. Okay, we're healthcare providers, we're human beings. There is going to be errors. Okay, we do have the statistics. We've all delivered, how many thousand courses of radiotherapy. It is inevitable that you will be involved in an incident of some description, but to cover it up is unforgivable. To not report these things, it really is unforgivable. And then to fail to learn is inexcusable. So, there's no point reporting. You also have to have some method of, analyzing it and disseminating the findings, implementing additional safety checks. So the incident learning system, that it does cover all of these bases. It's not just reporting. So types of incidents in RT, and this is, we did cover this as well entirely within the Marlin project, within the guidelines, what is, how you define a near miss, how you define an adverse error event and a significant event, and, what we would recommend from a reporting point of view for each of these specific events. So we have incidents, which is the umbrella term. So incidents can be near misses, but very good for learning. But then we can have an event involving accidental or unintended medical exposures. So this could be an adverse error event where, it does result in harm to the patient, which is considered significant events. And there can also be minor or no harm event where there was accidental or unintended medical exposure, but following analysis, usually some type of dosimetric check, that there really is minor or no harm event is what it was classified as. So to support reporting all types of incidents, because we're not just, obviously the significant events, that's very, very important, but that's not what we're just interested in here. We are interested in the voluntary reporting, which is all of the events and your near misses. So for mandatory reporting, which is going to be significant events, those would be reported nationally. Those would be, a significant event would be defined by your competent authority. And the competent authority, then they would have a system for reporting those events to the competent authority. So that's your mandatory reporting, which has to be done. It's legislated for at a European level and at a national level. But then you have your voluntary reporting, where you can send all events, okay, insignificant events included, okay, so there is a little bit of double entry there, but it's also your near misses, like non-compliance and like, non-conformity. These are other types of incidents that we're seeing like arise as well. So you can report these as well. You can either have for your voluntary reporting, it can be a local system within your hospital, okay, local system within your hospital, a national one. So obviously with a local system within your hospital, reporting is always good. We're always happy to see reporting. But if, have a small department with like, maybe 2 linear accelerators, maybe, reporting to a national system, amalgamating a few different local systems would be good from a learning point of view, that knowledge transfer. And then there is international voluntary reporting instant learning systems. So I have to mention ROSIS, okay, which is Estro's system, which Mary Coffey was very much involved in its inception and its ongoing development, which at the moment is being redeveloped and will be launched very, very soon. And Saffron, which is from the IAEA. So Saffron as well, very much based on the ROSIS program. And with ROSIS and Saffron, the vision was there is that local, like, individual clinical facilities could use this, to meet their needs. Like it could be a local system, but also you could filter to be able to identify centres in your, national centres and to look at the data overall there. So, the advantage there is they're already established ILSs and you can like tailor it to use it how you want to use it. So that's the types of instant learning systems out there. And we do talk within the consensus guidelines about these options and, what may work for you in your clinical facility. So the significant event then is defined by the competent authority, so the national regulator. So criterion for significant event, and this is what we saw when we were doing the consensus guidelines, is like it's usually based on some type of dose variation, either a dose variation per fraction or for the whole course, or the number of patients affected. While it might not meet, say, dose criterion, it could, and if it was a number of patients affected, it could indicate a systematic issue, within a department. So in Ireland, I can speak about Ireland for the moment, because in Ireland we have HICWA and they are the competent authority and they define significant events. And this, again, this is all available online. Anyone can access it online. But when we talk about radiotherapy specifically and ionizing radiation, that's why it's 14, 15, 16 and 17. So they talk about, again, that dose or volume variation from the total prescribed or else from the fraction prescribed. Now, unexpected tissue reactions as a result of radiotherapy treatment. So this is something that might be observed like, during treatment or after follow-up. And it could indicate that there, might be an issue with the calibration of the treatment planning system or of the actual linear accelerator. And it is something that would need to be investigated. Or it could be any other radiation exposure incident considered to have serious service user safety implications. So it's non-notifiable from, say, these thresholds. But if we're seeing a large number, it is indicative of some kind of systematic issue that should be reported. And the reason why it should be reported is if it's, say, an issue with like a particular type of manufacturer, and this machine is being used like worldwide, it is important that it is identified here. So if we think about, what type of incidents, like us as healthcare providers, radiation therapists, what type of incidents are common in RT? So this article was published in 2023, and it is essentially Saffron, so the international voluntary ILS, and they provided basically an overview of the incidents that have been reported from its inception in 2012. And you can see here within the voluntary system, you can, because, you are using the voluntary system for a very different reason, you can change the categorization of incidents. You can talk about minor incidents, potential serious incident, which is a near miss that could have been a serious incident. And then, a serious incident and a potential major incident. So, you can, they are categorized, but it's really just so you can be filtering it and identifying, the types of incident that you also, that you want to be using for your specific learning. So types of incidents, so they did find that there was just under 2,000 were reported, but they only analysed 256, mainly because the incidents that were excluded, they just didn't provide any kind of safety barriers or any of that important information that would be quite useful from a learning point of view. And you can see here, we are looking at largely minor incidents overall, thankfully, these major incidents, significant events, etc., they are relatively rare. So we are looking at a lot of minor events, but they are very, very important from a learning point of view, and to anticipate and mitigate any significant event happening down the line. Now, interestingly as well, and this is something that we should be taking into account when we look at the causes of incidents. If you look here, the top 4 here, responsible really for the vast majority, it's really inadequate information, standard practice not followed, communication, inadequate documentation. So a lot of them are related to communication issues, which is quite common across healthcare in general, not just RT specific. But something else which was very, very positive as well from this is the safety barriers which identify the incidents. And you can see here, the majority is those independent chart checks. So these safety barriers that we do have in place, they are very, very, they are very useful, they are very valuable, and they do identify incidents. And that is something that we have throughout our patient pathway, and with very good reason. So back to Marlin, and from the RT perspective, because obviously I'm not an expert in interventional radiology or diagnostic radiography or anything like that. So, speaking from the RT perspective, so the expert consortium, ESTRO and EFOMP, as well as the EIBIR. So the first thing that we had to do was provide a comprehensive description of the current status of incident reporting across Europe. That's very important. Consensus guidelines. What are people currently doing? So what is realistic from a consensus guidelines point of view? And then developing the consensus guidelines on reporting and learning. This is what we had to do. So we had 2 objectives. So the project layout, it consisted of 5 different work packages. So work package 1, so this obviously took place over the 24 months. So work package 1 was assessing what is currently being done, which was the survey on the implementation of legal requirements and just general reporting and learning. And then work package 2, so that's where, all of the experts in the consortium, they drafted what they considered guidelines for their specific area of expertise. Then work package 3, there was consultation with the main stakeholders across Europe because it's consensus guidelines. And then work package 4 was the workshop, which took place in September, where there was presentation based on the draft guidelines, including the feedback from work package 3 consultation, were presented for further discussion and consensus. And then work package 5, which is the last part, which will take place over the coming months, will be that dissemination of the guidelines, publicizing it, and just what we have done and what we hope that this Marlin project will achieve. So we had regular consortium meetings with the European Commission during this 24-month period, and just to make sure that we were on track with these deliverables. So work package 1, we had a very good representation of responses. So we do feel that it was a good representation of what has been done at a European level. So from the competent authorities, from the professional societies, so you can see here from 23 countries, 28 countries, from 19 countries. So, we did have a good representation of responses. So I do apologize, but I'm just not at liberty yet to provide too much in-depth information about the findings from these specific work packages. They will be published at a later date. That's part of work package 5 and the dissemination of the findings from these earlier studies, as well as the guidelines. But in terms of the competent authority, we did the survey questions was very much about inspections, the prevalence of inspections at a European level, how significant offences are defined, how the competent authority analyzes incidents that are reported and how they disseminate the lessons learned, and then the number of significant events reported per country throughout Europe. Now, we did see quite a lot of variation throughout Europe. Like, inspections are quite common. In defining significant events, we did find that not all the competent authorities do that. Sometimes that was actually the professional society, which was quite interesting. And then there was obviously different mechanisms in place for how incidents were analysed and the lessons were disseminated afterwards. And it's not unusual that there was definitely regional variations in the significant events reported per country throughout Europe. And there are some factors that we can definitely consider that would be attributed to that trend that we saw. So the clinical facilities as well. So mainly we were interested in like the types of, instant learning systems in operation. Like, are they using a local one, a national one, generic, or is it RT specific? Because obviously within like, an RT department, it might be a part of like a hospital organization where there would be a hospital, ILS, which is obviously good because reporting is good, but sometimes the issue with, hospital rather than RT specific ILSs is that there might be a limitation in the valuable information that you can input in there, rather than an RT specific one, which is just going to be very specific to the patient pathway within RT. Whereas with a generic one, you're covering like, all incidents in a hospital, from falls to, incorrect like medication, like making issues with like, where there might have been communication issues with patients. So, it can lack just that specificity, but obviously any type of reporting is good. Who can report the events? This obviously there was variation here as well. We did see that like in some centres, all staff could report events, whereas in some centres it was no specific staff only. The analysis of incidents, this was interesting as well. We did find that the analysis of incidents was a little bit less structured from department to department, and also like how the findings were disseminated. And that is actually something in work package 3 that people were a little bit frustrated about, is like, I do report, but I never hear anything about the analysis afterwards. So this is something that we have really highlighted and emphasized in the consensus guidelines. Now, staff protection is it's obviously quite a sensitive issue as well. So in terms of staff protection, what you can have here is, a just culture. Okay, you can have confidential reporting, or you can have anonymous reporting, and they do come with their limitations, specifically in terms of the anonymous reporting, because often you will have to follow up with a staff member, to get further information to complete the analysis. So there definitely is an argument for confidential rather than anonymous reporting, but then it's kind of like that balance, of trying to encourage reporting and any fear of kind of retribution, which can be an issue. Like we did notice that probably there isn't a very positive culture of reporting throughout Europe. And then the governance structure for event analysis, this can really vary. Some departments are quite structured in terms of having like a radiation safety committee, like an incident learning committee. And this does like having that like very established system for analysing events. And then what kind of service improvements following incident analysis are implemented. So the professional society is not legislated for, but it was very important to get their point of view, specifically as like within ESTRO, for example, there is, which I'm a member of, is the ROS committee, Radiation Oncology Safety and Quality Committee, and professional societies do often have a safety quality committee within there. So of course they are going to be interested in ILS and their opinions on the role of the professional societies in incident reporting and learning, which is very positive. Even though these professional societies, a lot of people are volunteering their time, they are very passionate about advocating, for safety and quality in the provision of healthcare. And it is something that they do want to be involved in. And they did have lots of good suggestions about how they could get further involved. We also completed a literature review because we have such an established, instant like safety culture in radiotherapy. There is plenty of literature out there. And we did find that critical really for a successful ILS, and this is just all findings that we would have been taken into consideration when we were drafting the guidelines, is like, this just culture, standardized terminology and procedure, because, if you want to be able to compare data across different centres, we all have to have a standardized way and common taxonomies for reporting. Efficient data collection, double entry. This can be an issue specifically, if you're going to have mandatory reporting and voluntary reporting. We're all very busy healthcare providers, like, within departments. Feedback to users, this was actually surprising to me, is that like this is something that is very frustrating for staff, is that when there is no feedback regarding an incident that they possibly reported. Voluntary reporting, the learning aspect here, and focus on improvement where, like it's non-punitive, like, you're not trying to blame someone here. It's about improving, and about improving basically the safety and quality of the treatment you're delivering. Efficiency in the analysis and the response, not that you've reported something and you don't hear about it for years. Compatibility with other systems, because, double entry, it's something that, we do want to avoid. And then the golden rules is you do need that positive leadership there. And you do need to have like either a confidential or anonymous system. And, there is obviously pros and cons associated with the anonymous system if you do want to follow up for more information. But one way you can get across this is if you have like a very established framework for reporting an incident. And my colleague who was part, Dr. Anita O'Donovan, and there is a webinar available within this series. You can watch it back, but basically Anita presented the AAPM, their task group 288, where they came up with consensus recommendations for incident narrative formatting, so that we're all submitting the same kind of valuable information for the analysis. So you can access that webinar as well within this series. And ease of access. Okay, so these are all, things that we took into consideration. I won't go through them for the interest of time. So we use the findings from Work Package 1 and the literature review, and obviously the contributions from the consortium members to develop this draft 1 guidelines for review by the advisory board. The advisory board was made up of experts from professional societies, from clinical facilities, internationally. So that was made up, that was our advisory board. So they did have a look at the consensus at the draft guidelines. We also had the big Work Package 3, which was the consultation with the stakeholders. So this was national competent authorities, professional societies, clinical facilities, and international and European organizations. So they were sent the basically they were sent the guidelines, and they were asked for any feedback, and each specific area was represented, and individual stakeholders were contacted where necessary if they did make some type of comment that there wasn't a lot of clarity there. And every single comment was addressed by the consortium and was implemented into the guidelines where we saw that it was appropriate. And then we presented these guidelines in September 2024. So I suppose to finish off today, like what will be covered in the guidelines? So we do talk about the merits of the types of ILSs that you have, okay, your generic or your hospital-based one. Now, obviously, hospital-based is better than none, okay? Sorry, I meant generic there, or T-specific. So it's better than none, but there can be limitations. But this is where, if you follow the task group's recommendations for that narrative reporting, where you could really maximize the usefulness of the generic hospital ILS. So the role of the competent authority, the professional society, and the clinical facilities in ILS implementation is discussed there, and the possible roles and responsibilities of each. Now, we do provide criteria for reporting significant events. Now, there was a lot, as you can imagine, there was a lot of back and forth on this, because different countries had different criterion for reporting significant events based on their own practices. And we do talk about, recommend taxonomies for reporting, that you are providing, enough information to be able to analyze it in a valuable way, but that it's not going to be too burdensome for the reporter to report. And then the options for local, national, and international systems. Now, we did talk about the no blame and just culture and second victim, because, this is something that did come up in the stakeholder feedback. There still is, a lot of fear of retribution. And it is something that does discourage reporting. So we try to have like a balanced kind of, recommendations regarding how you address these within the guidelines. But most importantly, what we did really kind of just try to highlight within this is that it's not just about the reporting, it's really about the comprehensive ILS, and that there is a system in place for the analysis of the events. And you do learn from it that there is strategies in place for disseminating the lessons learned. That it's not just when a significant event happens and it gets, to the press, that there actually is staff, you know, they learn what type of incidents happened this year or this month even. We do provide recommendations for that periodic dissemination of the lessons learned. And it is a comprehensive ILS. And, you know, this is just, so Carlos was he was the clinical coordinator. So he did provide some kind of, you know, basically like, you know, organizational structure for, you know, how you meet, you know, your significant events, okay, reporting those to the competent authority, and also following up with the competent authority regarding these events, but also, you know, your voluntary reporting at a local level, and, you know, whether you have an incident learning committee, a radiation safety committee, or quality and safety department, like, you know, how these people all work together to make sure that these events are analysed and they are, and the lessons are, well, basically safety barriers are put in place to address them, but also that there are, you know, the lessons, disseminate the lessons from it. And so this is something, there's a few different, there's a few different organizational structures recommended within there. And again, really just extremely important part. The learning aspect here is very, very important. You know, I think we're pretty good for reporting, but I think the learning is something that, you know, we could probably work on a little bit more, which is what the guidelines really do concentrate on. Recommendations for disseminating the findings is provided, okay, because, and again, this is where the professional societies were quite important as well. And they were a group that we couldn't leave out, because, say, for example, there is an adverse event and, you know, there is an issue that, you know, that the media are covering. It is inevitable that, you know, the professional society will probably be approached for a comment on this. And then emphasis then really on the provision of resources for an efficient ILS, because, you know, we did find from the survey that it's almost an optional extra in a clinical facility at the moment, bar the mandatory reporting, which obviously has to be done because it is a legal requirement. So, you know, that, yeah, that organizations are taking this into account, and they are actually, you know, they are providing and they are making a provision for having a very efficient ILS and the Incident Learning Committee and the Radiation and Safety and Quality and you know, a Radiation Safety Quality Committee in place to be ordered to be able to do this. So so in terms of, like, you know, more comprehensive findings from there. So the project will be ending in December. Work Package 5 will talk about the dissemination then of, you know, the findings from those original studies and also the actual guidelines, but that would be sometimes earlier in the new year. So if you do look out for any type of, it will be well publicized as well when we're launching those. So if you want to look out for that. And I will finish there, and I'm happy to take any questions. I'll just stop sharing my screen. Thank you for your time.
Brilliant. Thanks very much, Maeve. I've certainly learned a lot about that project from that presentation, so it was very comprehensive. So thanks for sharing your experience on the project with us. Just to remind people, you can put your questions in Q&A, please, not in chat, because we can't see them in chat for some reason. But if you put them in Q&A, we can see them there. But while people are having a think about questions, Maeve, I was just wondering about, I suppose I kind of noticed as you were going through it that the patient was in the middle all the time. But were patients actually involved as part of this group or not? Were there any patient representatives?
There was a patient representative, yeah, on the advisory board. Yeah, we did have a patient representative who, yeah, I can divulge this group here, but definitely when it came to the just culture and the second victim, this, you know, when I talk about the second victim, this is essentially the person who was involved in the incident, which unfortunately would probably be all of us there. And, you know, it sometimes, I think I think the patient representative found that, like, they're not a victim, really, are they? But, you know, but that's, I suppose, where the consortium is like, you know, if this happens in a department, like they feel dreadful, like they really are, and there are, you know, escalation plans and strategies in place to support that person.
Okay, so it's quite, I suppose everyone has a slightly different perspective on it, depending on where you are in the day. And was there any consensus about, sorry, because I know you can't divulge everything to us, but about how patients should be notified of an incident? Was there any kind of consensus around how that should happen?
Yeah, that is addressed, because that's obviously a very, very important part of the ILS and how and yeah, the patient being involved and the full disclosure. So that is addressed in the guidelines. And yeah, there was consensus regarding that. There does seem to be a positive culture in terms of informing the patient. And
Yeah.
but interestingly, if we look at radiation therapy specifically, it would be the radiation oncologist that would be responsible there, and they're not usually involved in incidents. Like they don't tend to be the people that detect them. It's the radiation therapist. So the important thing is like involving the whole multidisciplinary team, because you are going to be involved in incidents, whether it's analysis or if it's informing a patient at some point. It's just going to be part of basically the hospital organization.
Yeah, interesting. Sarah has a question there. Thanks, Sarah. Do you think it'll be a challenge to disseminate the guidelines to clinical hospitals in order to help improve practice in this area?
It will be. I can tell you why, because there is variations in the practice, and there is a reluctance to report in some regional. There was definitely regions where reporting it's something that radiation therapists do not want to do because of the consequences of that. So this is where I suppose not just publishing and distributing the guidelines, but where you actually have further webinars organized at the Marlin level, just to really highlight what we are trying to do with these guidelines. And there is variations, like the mandatory reporting as well. Like we did notice that particularly France, particularly like Belgium, like they had pretty significant incidents, and as a result they had a lot of investment and a lot of I don't like to say embracing it, but looking at the ILS from that point of view. So I do think that we can definitely learn from regions where they have a very positive safety culture that was implemented after like quite a significant event happening. But it's how you learn from these things. But there will be issues there, but the EC were very, because at points as well, just to follow on from that question, there was a lot of discussion, particularly from the stakeholder feedback, that these guidelines, they're too prescriptive. And then some people were saying, these aren't prescriptive enough. You're kind of saying should and should. But the EC were very supportive of that. This is a framework for people to work with. Okay, this is a framework to encourage a level of consensus here. So, and that's what we have tried to do. We've tried to really like reconcile being too prescriptive versus actually, they are guidelines at the end of the day and recommendations. So I hope we've managed to strike that balance there.
It's always difficult in those pan-European projects because there's such a variety of practice and opinion, and as you say, the culture that people are working in can be very hierarchical in some settings, and then very collaborative in others, and finding that middle ground I think is always very difficult. It does sound like you nearly need, I'm giving you another project now, it sounds like you really need nearly an implementation science follow-on project of actually local kind of champions on the ground implementing the guidelines. Sometimes I think we miss that final step in some of these projects, that I've been involved in myself as well, that we produce the guidelines, but we need kind of boots on the ground to actually see their implementation through to fruition. So just trying to give you another project there, Maeve.
No, I would agree. Obviously, Work Package 5, like that's something that they will be working on. Well, I'll be involved in some capacity, and like not even like, but even when we look at the criterion, like, and this is something that we did discuss as well. But when we look at hyperfractionation, like we will have to consider that when we're defining significant events going forward, because with reduced fractions where you might have had the opportunity to compensate, that's going to start becoming quite limited as well. So there was a lot of discussions, but for the EC, it was like, this is a framework. Okay, we can't be too descriptive here, and it is mainly because you want, as you said, that buy-in from everybody.
Yeah, I was wondering then about I mean, I totally understand when people were saying that we're very frustrated that they were reporting incidents and they're not hearing anything about it afterwards. You know what I mean? Or there's no learning from it. Did the group come to any consensus about how to increase positivity around reporting? Because you can obviously imagine that if you're reporting incidents very diligently and then you hear nothing, you might be disenfranchised to do so the next time. Do you know what I mean? So did you get to any kind of consensus about how to do that? Or
there was actually quite a lot of discussion about that at the workshop, and there was many points of view that who should be involved, first of all, in the analysis. And,
Yeah.
some people were very like, no, it should just be the heads of department because they're the ones that are going to be involved in making any changes, which I would agree with. But I
Mm.
also agree that there shouldn't be this corridor of power where,
Yeah.
an incident you've reported is being
Mm.
discussed and you hear absolutely nothing about it. So,
Mm.
I do agree that, yeah, it does need to be the people that can make decisions discussing it, but to disseminate the findings. And like a few things that are recommended is that you have like, it's almost like a standing, agenda item in a staff meeting or in a bulletin,
Mm.
incidents this month where this is just part of what we do. Like,
Mm.
like it's not
Mm.
reflective of bad practice. Like, there is a point, okay, where it's like, okay, just culture will have to come in here. And I know in Ireland there certainly is a framework for, what's considered just culture, or when, perhaps, just culture can't be applied here. Um,
Mhm.
but it's just about making it like normal. This is something that's going to happen, and we're going to learn from them. Okay, like, and
Yeah.
it's and encouraging that reporting. But some things was like kind of like, yeah, bulletins and staff newsletters, emails, where people are just kept up to date with what's happening. But yeah, there was a lot of discussion surrounding, yeah, who's actually
Mhm.
involved, and
Yeah.
that's something that certainly the competent authorities there were very much discouraging that this becomes like I said, their corridor of power
Yeah. Yeah. Yeah.
there.
Because I mean, that really would that would
Mm,
really incentivize you to report, wouldn't it?
it is.
I was wondering then, did you notice that there was a very in the survey that you did in the first work package, was there a very obvious kind of geographical difference in kind of no blame culture from, one area of Europe to another? Or was that actually analysed?
That was more, that's something that was probably clear when it came to the stakeholder feedback in work package 3,
Mm-hmm.
because at that point we were providing what we were recommending, and in terms of what we were recommending in terms of like open disclosure and in terms of like reporter protection, and like there was a lot of people saying, yeah, we definitely don't have that, and I cannot
Okay.
see that happening in our department. So that was where, when we had laid it out that this is what we're hoping
Mm-hmm.
that is going to happen, that we were seeing kind of like, yeah, the not necessarily the resistance, but probably, reluctance from certain
Yeah.
geographical regions. Now, not many, certainly, but certainly a few. But I think you are right when it comes to like your local champions, because like there are plenty of departments that are doing very positive things when it
Yes, of
comes to
course.
instant learning, and something that they're constantly looking at.
Mm-hmm.
Um, and I think it's again, it's just looking at it as from a positive point of view, rather than like, something that, we don't talk about anymore.
Mm-hmm. And I know with the relaunch of Roses coming on stream soon,
Mm,
I was just actually thinking about, because I understand that some people obviously have local incident reporting and learning systems, and some have national, and they're obliged to have national ones. But I mean, really, from, I suppose I'm sitting here thinking with a cost effectiveness hat on, from a cost effectiveness point of view, it would seem much more sensible to feed into, a system like Roses that is being
mm.
relaunched, or Saffron if you're obviously not in Europe, in order to report your incidents. Was there any kind of
Yeah.
those views
So
around that?
yeah, so within within the guidelines as well, when we're talking about voluntary reporting, the different types of systems, and also like, if you don't have the resources in place, there
Mm,
are established systems here that
yeah.
you can link in with, and you can,
Mm,
use as you see fit for your department. But certainly, because this is like, it's been housed, it's,
mhm,
from an IT point of view, because obviously, like these
mm,
incidents, like how you analyze them afterwards, that's, a lot of work in itself.
mhm,
Sometimes it might just be as well an Excel sheet in some
mhm.
departments. But if you have like a
Yeah.
very, yes, like kind of like a smooth established system like your Roses or
Mhm,
Saffron,
mhm.
would definitely recommend that people do
Yeah.
report to these systems. Yeah.
Yeah, and having had a sneak preview of the revamped Roses, it's actually very easy to use, isn't it? So,
Yeah. Yeah.
it actually be a lot easier to use in Excel, I would have thought. So,
And it's
anyway, I think we don't have any other questions, Maeve. You and I could stay chatting about this for a while longer, but I think our time is up. So look, thanks so much for such an excellent and comprehensive overview of that project. And you said it's ending in December, so I guess by the time the final report goes through the European channels, it'd probably be Q1 next year, I suppose, before that's available. Yeah.
I would add to the audience to definitely be looking out for any kind of releases regarding this, and of course the relaunch of ROSAS. It's all kind of like nice time nicely. If people are kind of reviewing their ILSs in their respective departments.
Yeah, brilliant. Thanks so much. So thanks, Maeve, that was terrific. So thank you all for joining us, whether it was live or on later on that you're catching up with us. I suppose I just want to let you know that next month's CPD webinar is on a totally different topic. You know, we like to have different things for different people. So next month on the 13th of November, I'll be joined by Professor Sarah Faithful, who is going to discuss late effects of radiation therapy. So I hope you can join us for that one in November. But otherwise, enjoy the rest of your day, and thanks for joining us. Bye-bye.